Our next speaker after lunch, Dr. Sin Hang Lee, is going to speak to us about cervical cancer prevention without harm.
Okay. Before I speak, I want to make a few sentences explanation where I'm coming from. As you know that the message here I'm presenting, thank you very much for inviting me to here, for the committee here, may not be well accepted by the mainstream medicine and by the healthcare industry. So therefore, the character assassination is one of the methods people to neutralize what I'm trying to say today, right? So that's one of the way to character assassin someone is to say, okay, this guy came from China, so he must have a poor medical education. So I want to explain to that. Okay. I can speak on it.
Yes.
Okay. So after I graduated from China, so I went to Hong Kong. Well, I was born in Hong Kong as a British subject before the war. Then I went to China, tried to become a professor in medicine. And as you know, that in the 1950s, there was political turmoil, it didn't work out. So I went to Hong Kong. So I joined the University of Hong Kong. And in Hong Kong at the time was a British colony. And they did not accept the Chinese qualification. So the only way to practice medicine in Hong Kong was to get a British license to be admitted to GMC, and GMC principal list, something like that, right? You know that. And I went to United States, and after Hong Kong, and I went to Canada, to get a British Commonwealth medical license. And my wife came to Ireland, and so she spent 2 years in Ireland, in Malta, Rotunda, and UDC to get her Irish license in order to join me to Hong Kong to practice medicine. That was the intention. But we changed our mind, so we continue to practice medicine, to do research in the United States and in Canada. So that's why I am qualified to practice medicine in China, in the United States, and Canada, and the British Commonwealth. So that, just if anybody want to attack me, just do it. And then I passed the examination to be admitted to the Fellow Royal College, in Canada in those days. And in those days, they limited the successful candidates for pathology. Each year they passed 4 to 6 people. So I was one of the 6 to pass in 1966. So in that case, so I was a physician, to pass the examination, compete with the internal medical people. So, and then I was qualified as a pathologist in the United States. Now, for those of you who are not familiar with what pathologists are doing, pathology is a specialty to study why people get sick or die, or how, sometimes we don't know why, and how they get sick and how they die, right? This is important. And however, no one pays for that, right? So you study, who pays for that? So how did I make a living? So I became a surgical pathologist, to advise the surgeons when to cut, when not to cut, how much to cut. Okay, so that is the way I make a living. As you know, that in 30, 40 years ago, before the CAT scan, the MRI, all the sketches, that most of the time when the surgeon opened the belly or the head, they didn't know what the hell they were cutting, right? So I would tell them, it's malignant, you cut. It's benign, close, right? Basically, very simple. The old way the pathologist got to be taught is the old pathology teacher taught us used to be saying that as a pathologist, you must think a lot. very widely, but say very little, and put down 2 words on paper, malignant or benign. Right? If it's malignant, the pressure came off right away. Right? So you better be good. So, and they pay very well for that. So that's how I make living. So how I get into HPV vaccine? That's all by accident. Because part of my duty was to read Pap smear. Pap smear. And I did my residency at Cornell New Hospital. As some of you may know, George Papanikolaou developed his Pap smear in New York Hospital. So I studied the set of slides George Papanikolaou left at Cornell. So I had good material to start with. So after that, So afterwards, I have been reading Pap smear for 40, 50 years, and the HPV test came in. Okay, and they said HPV test is a cancer test. I said no, it is not. It tests the virology infection. It's not a cancer test. And actually, I brought the FDA to court to sue the FDA. I said you misclassified a virology test as a cancer test. As you know, that because of sovereign immunity protection law, you cannot sue the U.S. government agency for any of this. So that I knew I lost the case, but the FDA agreed that my test will be probably superior than FDA-approved kits for DNA sequencing, DNA sequencing, to be accurate. So, and then the vaccine came in 2006. So I developed the most sensitive and accurate diagnostic HPV test, and I published a paper. I sued FDA. And then a bunch of women, the mothers, who thought their daughters were injured by Gardasil vaccine, contact me and say, it's very interesting. People said, in history, the real revolutions are only 2. One occurred when Gutenberg introduced the removable printing to mass produce the Bible. So everybody, every peasant had a Bible to read, right? So in that case, they have the power. Before that, the power was in the hand of the priest. But now everybody can read, right? Knowledge is the power. So this is one time this revolution occurred. The second revolution is this thing, internet, right? And every woman, mother who started got sick and being classified as a psychosomatic reaction or that, and they didn't believe it. They went to the internet to look it up. Right? They found out Dr. Lee could diagnose, HPV DNA very accurately, sensitively. So they contact me, whether I could do it. And they have no money, of course. And I said, okay, in order for me to do it, since I'm a licensed doctor, I cannot order self-referred tests in a clear lab. I said, you have to order for me to do it. So why don't you sign a contract with me for $1? So in case that, I just send a bill. So, this is business transaction. That's how we recover legally. Otherwise, the milk said, you probably want to download the downtrend of the milk stock. You try to hurt us, right? So I didn't have that kind of intention because I did it on a contract. That's one thing to cover myself. Okay, that's how I got into the vaccine test. Okay. I said, okay, I will try to test it, but I cannot, guarantee the result. So that's okay. All right. So that's briefly to talk about the background. Before I go into science and medicine in detail, I want to put a few words in vaccinology, vaccine in general. Okay. there are two kinds of vaccine broadly. Yeah. One kind of vaccine uses attenuated pathogen, okay, like a smallpox vaccine or BCG vaccine, smallpox against the cowpox, right? Everybody probably had cowpox vaccine when you were born, right? And the BCG vaccine to prevent tuberculosis, right? These are attenuated, live bacteria. You don't need adjuvant on that, okay? Because the vaccine, BCG, is one of the components in experimental research as a front adjuvant. You add dead bacteria. If you want to produce antigen against a protein antigen, you have to add front adjuvant, which contains dead BCG into the substance. It's called a complete front adjuvant. And people didn't know why for decades until very recently. Okay. And then another kind of vaccine is component vaccine, like protein, right? Like HPV vaccine is a protein. So protein, you need to have to add adjuvant. If you inject protein into the body, the immune system does not recognize danger. They don't react, don't respond accurately. So you have to put adjuvant into the body at the same time to cause inflammation, kind of reaction. Then the immune cells recognize, now this is danger, right? Let's respond how to fight. So vaccination is actually how you teach the immune system to fight the future infection by mimicking a small case of infection. To teach them, you make a less dangerous infective inflammatory reaction to teach the immune system. Now, in the future, you see the same thing, you got to fight harder, right? So you got to, by doing so, actually you create little damage. For example, if you have a cowpox inoculation, you always have a scar, right? Everybody has scar in the cow. Or BCG, the same way. Yeah? So vaccination, if you really want to produce the future effect, the good effect, long-lasting effect, you need to have some damage created. Actually, the damage, the virus, the bacteria, does not cause damage. Actually, the damage comes in your own body, the cytokines. And in the old days, we talk about the pyrogen endotoxin about the bacteria. And actually, when you have infection, you have fever, chill, right? The chill of fever, it was not caused by the bacteria substance. It's caused by the reactive substances. The cytokine, the tumor necrosis factor alpha, that causes you shivering, aching, and lost appetite, vomiting, fever. That's your own body. Your own body could produce something harmful to you. Yeah. That is a general concept vaccine. Okay, too much on the background, but you have to understand the background. So the background is that human intervention has always a risk of doing something which is not quite good, right? It's better to have no human intervention if it's possible, but sometimes you have to do it, right? For example, some vaccine you have to do it. So for smallpox, but you got to keep this in mind. Got to do this. Okay, the U.S. passed a law recently. Okay, it's called Advancing Precision Medicine. Okay, how to promote, encourage precision medicine initiatives to address disease prevention, diagnosis, and the treatment. Why I'm interested in this law? Because I'm involved in Lyme disease diagnosis. If anybody knows of Lyme disease, you know how difficult the diagnosis is. So I have the good method to diagnosis. I just sue the CDC for that. I'm a lawyer, so that's why I'm interested in that. Part of it, within the working group. But I don't think the working group is going to do anything anyway. But I can talk. So even the president, politicians recognize the importance of precision medicine. And when he talked, he put a double-stranded DNA model next to it, right? So that's how important. So my job is to study DNA sequencing. And actually, I was a few years ahead of him. When he was elected, I was invited to, in 2009 to give a talk about HPV industry. At the time, how to manage women's cervical cancer possibility. And the industry spent about $10 billion at that time for that. It's on the record. So it was done at expenses of women's health over colposcopy biopsy. Okay? It's overdone. And especially when the HPV test was introduced, and people say, okay, you have HPV 16, you have HPV 18, and refer the women to the OR for surgical biopsy. That is a fee. The procedural fee the gynecologist can charge. The pathology like it because they have the slides too to read it and charge fee. So, but that's at the expenses of over procedural damage to the women. So I said you should not do that, and you should have a more accurate test for HPV and reduce the number of surgery to do accurate tests. Pap smear, HPV tests do not harm the women, but biopsy, the cone biopsy, the liver, those produce harm. So that was my message at the time. Now, this just to prove I was not against HPV vaccination. I published the first paper in 2007. At the time, I said it would be prudent to perform a genotype-specific HPV assay if prior HPV infection is suspected, right? So basically what I'm saying is that I have developed a very sensitive, accurate HPV testing before any woman who is going to get a vaccine and test, make sure they don't have HPV 16 or 18 infection. Otherwise, you may introduce harm by introducing a vaccine relevant HPV persistent infection. It's immune reaction around the cervix, and that is the danger. It's not a vaccine infection. It's not an HPV infection. It's a persistent infection. So what I'm trying to say, what I'm trying to do at my age, is to introduce an evidence-based practice medicine. As you all know, when the cardiologist issue a left lunge block, your patient that somebody old enough probably would heard about it, left lunge block of the heart disease. When they do that, they give EKG on that. When the neurologist diagnose seizure, instead of a truly psychosomatic reaction, right? So they have an EEG to prove it. So I said, if any pathologist issue a report of HPV infection, they should give a segment of Sanger sequencing to prove this is HPV 18 or 16 type. What's so important? The likelihood of making an error, a random peak errors in this segment is 1 to the 16 or 1 to the 60 is 0. The chances is very minimal. That's how the gene bank statistic give us. Okay. Why I said vaccine is not necessary. because cervical cancer is not a common disease and most preventable disease. And this was a testimony given by Dr. Nancy Lee, has no relation to me, to the committee of the Congress at the time. So the average age for women who have cancer is 54 at the time, and the survival is 100%. If you detect the cancer on the way of being cancer, or the pre-cancer stages, so you resect it, it's 100% preventable. Even when you find cancer, when invasive cancer, means the cancer is already invaded through the epithelium, get to the stroma, and the cure rate is almost 100%. 100%. So actually, cervical cancer is a disease or the death for the women who have not been well screened or don't go to see a gynecologist due to self-neglect or due to the lack of provision by the government, by the system. So the important thing to prevent cervical cancer is to make sure they don't develop cancer before they do take action. So how infectious of HPV, cervical HPV? This is statistics released by the CDC. In the United States, from 1947, for 100 women, there are 44 women develop cervical cancer. But because of pap smear, then in 1990 it's reduced to 8.8. Now it's even further. Currently, 79 million American women are infected by HPV. And every year, 14 million new infections. So the existing women, 49 women, were infected by HPV, and only 14 women are infected every year, right? The new infection. So most of these women infected HPV do not get another new women to infected, right? So actually, right, the newly infection is less, than the number prevalent in the population. And now it's only 1.7 women would die per 100,000. This is statistic. So the HPV infection is not a contagious disease. It's not contagious disease. It's very important. It's not a contagious. What does it mean? For all the contagious diseases, there's R0, R0 value. What R0 value means? Measles is a highly contagious disease. For example, if there is one child in a classroom of this size, this child can infect 13 other children, right? With measles virus. For HPV, the R0 is less than 1. Well, what it means is that if there were one lady in this room who has HPV infection now by attending this meeting, and this HPV infected woman is not going to get another woman infected by HPV because of the women attending this meeting, correct? Right? If anybody disagree with me, just show me that any one of you attending this meeting can infect HPV by anyone because of you attending the meeting. It's not possible, right? The slim. So that's why it's not a contagious disease. And vaccine is to protect, to reduce infectious disease risk. So this is the wrong concept. Now, this is just a simple pathology to show in the HPV infection. This is called chondrocytes. Yeah, the virus particles are located in the cytoplasm in the clear cell area. This is low grade cytology. When it becomes cancerous or tumor cancerous, and then the so-called cytoplasmic to nuclear ratio decrease. There's more nucleus increase in size and less cytoplasm. And this is pap smear. So if you see this kind of lesion, you cut the susceptible surface out by a lip or cone biopsy, the cancer will be gone. The risk of cancer will be gone. And this picture to summarize a conceptual model of cervical cancer carcinogenesis. And as all cancer production, always goes through initiation, promotion, and progression process. When the HPV infection takes place at the first for the women, the average medium period for the HPV to clear by your immune system is 168 days. Yeah, they did this in the college student. Yeah, on the basis. And if any cellular changes will be reversible. Infection itself is not a risk. It's a persistent infection. HPV persistent infection. What a persistent infection means? The patient is infected with HPV 16 in January, in October, and next year, March, it still has HPV 16. Okay, this is a persistent infection. That means the woman cannot get rid of this HPV type. Okay, if the woman is infected by HPV 16 in January, by HPV 31 in June, or HPV 18 next year, it's not persistent infection, because this means only a repeated sequential infection, because this woman may have different sex partners during the year, and clear up in a month or two, right? So therefore, for HPV testing to follow up, the important thing is accurate genotyping, very accurate, very sensitive test, unless the woman is having persistent infection with one genotype, you don't have to do biopsy. Okay? Biopsy for cervix is harmful, like hemorrhoids. Yeah, many of you probably have hemorrhoids, experience with hemorrhoids. I had it 20 years ago. So when I have hemorrhoids, I talk to an old surgeon. The old surgeon said, "Dr. Lee, save the hemorrhoids. Don't do an operation." So I did. Just to change the lifestyle, the habit. I saved the hemorrhoid. Now it's gone. Right? So the surgeon, he didn't have to make any more money because he's retiring. So he told me the truth. Right? So that was so cervix the same way. Keep your cervix intact if it's possible. Right? So that's why I said okay. So for HPV infection, the following, you take about 15 to 20 years to get invasive cancer if it progresses to that stage. But most of them, these are reversible. And then, what are the problems? Is integration. I said, you have multiple children, oral contraceptive usage, smoking. All these are the promotional factors. Persistent infection and the host infection, all that. And you have to, the lifestyle here will affect this equation. That's important. Now, this just to show the reversible of precancerous changes. You have CIN2, CIN3, or the different percentage, they can reverse. I'm going to, everybody probably knows about it. I'm not saying to say about it. And this is one of the first paper published by Professor Bella from Israel. And among the clinical subjects in his clinical trial for HPV vaccination, 2 women died. Two women had invasive cancer during the trial. Before the clinical trial, everyone was a screen, right? They should not have any HPV infection or cancer, or precancer, or abnormalities before they went into the vaccine trial. And the 2 of them developed cancer, and he was surprised so quickly. And this is only 20-year-old women. And subsequently, and he found out, and it was not 16, it was 31. And in fact, now we know HPV 31 and HPV 16 has cross-reaction. They have cross-protection. When you have cross-protection, you have cross-reaction, right? So actually, he didn't know that at the time. Okay. So his conclusion at the time, also today, there's no definite evidence showing vaccine reduces incidence of cervical cancer. That was published in journal Gynecology and Obstetrics. And now, and this is one of the ladies here in this room, helped me to gather that, because I didn't follow this is statistics. And after HPV vaccination, there are still abnormality and cervical cancer, and these people have had vaccination but still develop precancer or invasive cancer lesions in their body. So the problem for HPV vaccination and the testing in replacing pap smear is that the experience was first established in Costa Rica. In Costa Rica, there is a valley called Guanacaste Valley, and that's known to be having a high incidence of cervical cancer in this population. Maybe genetic, maybe lifestyle. And they did this test on that and trying to translate the results to the first industrial country like Ireland, United States, and Canada, which is wrong. And this actually has been stated by the CDC. For all these sexually related tests developed in the red light district for the pharmaceutical company, the medical devices, it's easier to do the clinical trial in a high incidence rate population, the sex workers, right? When you have the data from this high rate incidence, the population, and try to translate it, import it into the US, Ireland, or Canada, there's a problem. Because the false positive will be much higher. This is it. And the HPV vaccine and that has the same kind of problem. And the current test here is quite current HPV test actually is quite inaccurate. 40% of them are in question. I participated in a New York State proficiency test. And I'm not going to repeat it here. You can see that. Because about 5 tests, right? And you have only 3 of them, 60% have consensus, and this is no consensus. So they don't grade on this. So at least 40% of them are questionable. Even this is quite debatable. Only one of the 100% agree. And all these people disagree. Right. Okay. How I got into this? Why I accepted the test for the women who requested me to do it. At the time, in Connecticut, there's one case. One of my fellow researchers at Yale, who was a neuropathologist, published a paper. It's a 16-year-old woman who got Gardasil 3 dosage and became paralyzed initially, and then has permanent loss of vision. And they called acute demyelinating encephalitis and published the paper. The reason they had the evidence because the infection in the brain mimicked tumor, right? They didn't know whether it was inflammation or cancer. They did a biopsy. Usually, if you have an encephalitis, you don't biopsy the brain. But you have a tumor-like lesions on MRI in the brain. So in order to differentiate the diagnosis, they biopsy. And they show this. This inflammation, with a lot of macrophages. So I know, okay, this may have something there. They believe, they believe that it was due to HPV infection or reaction to HPV vaccine. So they published the paper. So I said, okay, I'll do it. And also, one of the mothers living in Toronto sent me a report of her daughter, serology test. The report says the serum has HPV DNA in it. And I talked to the PhD, and he said yes. So, okay, in that case, I have to test whether the vaccine itself has HPV DNA in first before I do any human test. If the vaccine doesn't have HPV DNA, it wastes my time to do any human test. So, the reason I was reluctant to do it because Merck already said, no viral DNA left when they got approval on the vaccine. And then I found the DNA, and then I looked into it. The problem is that the sinkhole and the hearts and sudden death, and many of the girls die in a bathtub, under the shower, unexpectedly. Teenager, healthy, complete teenager, athletic teenager, drop dead. This is unheard of as a pathologist, because teenagers is very resistant to death. You see, they already survived the childhood infection, and the degenerative disease or heart disease hasn't come in yet, right? And that time is very healthy teenager. Why do they die? And when they die, they either they may have the congenital hyperlipidemia, clog up the artery, or hypertrophy of the heart. The autopsy, but the autopsy didn't show that. That's unbelievable. So it has something has to be there. So I tested the vaccine, and I found out the vaccine has this DNA. I submitted this vaccine to the gene bank. The gene bank said this is synthetic HPV 11 major capsid protein, and this segment of DNA was manufactured by Merck. The nature doesn't have it. I cannot create it in my lab. So this is signature sequencing of lab fingerprint in manufacturing the HPV. So we report to the FDA. The FDA could not refute that. So the FDA agreed. Said, Dr. Lee, yes, we agreed. You find out HPV fragments in the vaccine. So these are a bunch of vaccines sent from different countries. Everyone has it. HPV 11, HPV 18. But I could not find HPV 6 or 16 initially. Then I had to look back to test 5 lots from New Zealand. Because in New Zealand there was a girl who died after HPV vaccine injection, 3 of them, and I found HPV 16 in the blood. So I want to find out why 16, 18 in the blood, but I could not find in the vaccine. But in fact, there were. But I have to change the primer, change the condition to find the non-B conformation of 16 HPV in the vaccine. So it's non-B conformation. So this is DNA found in the spleen of the autopsy of the non-B conformation. Okay. Since the FDA agreed, the vaccine does contain the combined HPV DNA in it. Okay. So what HPV DNA in the vaccine has to do with all this post-Gardasil syndrome. The key here is autoimmune disease. And this is a table taken from the Gardasil prescription information. Okay? And it has all the autoimmune disease category here. And actually, as a pathologist, when you look at all these diseases, instead of individually, you take a helicopter going up to look at it. Actually, this is a human-made artificial division of autoimmune diseases. Yeah, and all depends on where the immune cells go. If you go to the thyroid, then you have Hashimoto. Yeah, if you go to the brain, you have multiple sclerosis. If you go to the joint, there's rheumatoid arthritis. You don't know where the macrophages, the inflammatory go, right? So actually, Mother Nature make the group of autoimmune disease, the human try to separate them to study, but we may be wrong, right? So, okay. Here, the important thing is, how do we get this? After vaccination, they send out a card to different people. You have reaction in 14 days after injection. You report what you have. 14 days. Okay. And in 14 days, so I look at the two cases I look into. One is multiple sclerosis. One is type 1 diabetes. Okay. And in this instance, I look at multiple sclerosis. If you calculated the incidence rate, it's not incidence. What Merck said is in 14 days, okay, in this group of clinical trial subjects, you only have 2 cases of multiple sclerosis reported to me on the card. You compare to the population, yeah, of incidence, there's no increase. Okay, so in fact, it's wrong. It should, in epidemiology, you should compare the number with the common denominator. The common denominator is incidence rate, not incidence. That means in 14 days, yeah, how many multiple sclerosis is diagnosed in this specific number of patients. Right? That is the key. So when you have the common denominator you compare, then you find out this actually is 350 times or 150 times higher for multiple sclerosis on that list. Yeah, I don't want to go into the arithmetic play for you. And before multiple sclerosis is diagnosed clinically, you have a stage called ADEM, acute demyelinating enteromyelitis. We have to wait until when this disease does not resolve, then multiple sclerosis diagnosis comes in, right? So when you look at the ADEM, incidence rate, this is European, this is American data. The HPV infection is number 1 or number 2 among all the vaccines. Okay, this is the brain infection, inflammation after the vaccine. And at this group, for example, you could see the HPV is higher because in this age group you don't have HPV vaccination. In the old age, you don't have HPV vaccination. The HPV vaccination only takes place in this group, right? So therefore, it's very high, right? When you compare with other vaccines. Now, the demyelinating syndrome here is also reported by an Australian group as a virus infection particles initiated. So, the role of milk adjuvant help increase the antigenicity of the virus-like particles. It's well known. It is adjuvant to increase the antibody production. Now, why antibody production is needed? That's based on the research advances in the last 15 to 20 years. Okay, and when aluminum was first introduced in vaccination, actually empirically we used it. We didn't know why it was important. We know adjuvant is important in vaccination, but why aluminum was important at the time? But now the medical community agrees. If you inject aluminum adjuvant with the vaccine, the aluminum as a metal substance will damage the cells. The cells will release ATP, DNA, uric acid. And these are actually adjuvant, not aluminum. The adjuvant may bring these things into the cells, right? And acting as a stimulant to the Th1, Th2 lymphocytes and cause inflammation. When you have protein presented to the lymphocytes don't see the danger. The lymphocytes have to see inflammation at the same time in order to react in terms of increased immune response. Now it's danger. We got to start to fight, right? So that's important. And this was the paper published by a group from UK to summarize the paper. Now it's known the toll-like receptor in the cell, the nucleus, the toll-like receptor. In a normal cell, you don't have DNA in the cytoplasm. Any DNA in the cytoplasm is abnormal. The immune cells try to get rid of them to fight, to find out why, to react. So you don't need aluminum. Virus-like particle itself can bring the DNA into the cell. The DNA, viral DNA, bacterial DNA, can act as a true adjuvant to activate this toll-like receptor, especially 9 receptor. I suggest you go back to look up the Nobel Assembly 2011 announcement, press on toll-like receptor discovery. The Nobel Prize rewarded to the 2 scientists who discovered toll-like receptor as the true adjuvant stimulator to activate the innate immune system. Okay, and the work was done before 2011, but the Nobel Prize was awarded in 2011, and now it's based on that. So why vaccination is more serious event? Because Gardner cell here, Gardner cell is a poor antigen. Has a poor antigen and needs toll-like receptor agonist, a ligand, to boost immunity for the reaction to be heightened to the level for long-term maintenance and high levels of antibody production in the body. And the problem is what kind of toll-like receptor is in it. In Cervix, it's proven that they use a salmonella lipid material to hook up with the aluminum soil, as a toll-like receptor 4 adjuvant. But in CAR cell, actually, they depend on toll-like receptor 9, which is HPV DNA. And they did not say it, and I found it. So people don't like it, but it's true there. Now, this is one way of increasing the autoimmune disease is to increase innate immune response, non-specifically. Okay. Another way is mimicry, molecular mimicry. Dr. Milford also talked about it before. But the toll-like receptor 9 is an intracellular receptor. And when it's activated, and it would secrete tubular necrosis factor alpha, interferon gamma, and others. And these are causing cells to kill the best cell, called the lymphocyte. You kill the virus. If you cannot kill the virus, kill the cells which contain the virus, right? If the virus don't have the cell, the virus will be dead, right? And that's the mechanism for it. Toll-like receptor 9 is to direct the lymphocyte to produce antibody. Okay, this is the two systems here. And the location is different. The toll-like receptor 4 is on the surface, and toll-like receptor 9 is in the cell, in the endosome. All right. And so when aluminum contains the DNA, it gets here, now on the surface, because the aluminum is in particle. It gets into the cell, got phagocytized. And this is another way to look at it. So toll-like receptor 9 and getting down to tumor necrosis alpha, interferon gamma, and these are the best things. And this way it produces antibody. But what we are worried about is this. And tumor necrosis alpha was used. The tumor necrosis factor is anti-cancer. Was used to treat cancer once upon a time because I found out it was too bad. It causes death, or the cardiac damage, and it gave up. And also in the nervous system, it can cause the multiple sclerosis because the toll-like receptor with the production of interferon gamma. Why Merck's manufacturing process left the DNA there? The important thing is that during the production, you produce the virus-like particles here. The DNA is left here, in between. If you take the solution, you may not find the DNA if you cut a piece like this. However, if you precipitate the virus-like particle, the DNA get into the aluminum, get to the cell. You got to test this part. And this is to show that AS04 for Cervix is approved by the FDA as an adjuvant. And for AAHS in glial cell, it was approved for hepatitis B vaccine, yeah, and it has to be loosely bound. If it's too tightly bound, it doesn't work. And for toll-like receptor, this is Cervical, yeah, it is approved. But for Garner cell, we have viral DNA like this, and the phospho group also attached to the aluminum. So you're competing, the two things can bind to aluminum. And this how the DNA bound to aluminum got into the cell, and the B conformation established. The DNA changes, so it's not easy to detect. It was discovered by a group of Japanese in 2003. And this is the normal way of how DNA get twisted, the non-B conformation. So therefore, when you have that, the DNA will resist degradation and become a long-term stimulant in the immune cell. That's the problem for Garner cell. And this is how the way the T cell will react to the foreign antigen, which can mimic the self-antigen. And I think this picture, this article, Dr. Wilson also cited before to show this, there's a similarity between the certain amino sequencing of the human genome and the HPV-16 genome. And you line up the 505 amino acids sequences in the HPV-16, you have many of them, 7 amino acids in group. So this can cause a similar antibody or immune cell reaction against your human substances, antigen. And if you have antibody with the antibody against the human DNA, and both of them combine and can become a toll-like receptor agonist, and to generate all the autoimmune responses in the body. So that's my final slide. Is that when I look at it, the cost of vaccination for $100,000 is about $70 million. Yeah, because you have a 3 dosage of $150 dosage plus doctor's fee, all that. And even if you vaccine 100% effective, you save life of 1.7 for 100 million women, and this death can be prevented by improved women's care. But even vaccination, after vaccination, you still have to screen cancer, cervical cancer anyway. So this added cost for vaccination is extra. So in addition, the human cost of 2.3% serious effect, serious side effect, adverse reactions, is very high. If you reduce the grade of a girl from the A student to C student, I think it's already serious. You don't have they don't have to die or cripple. It's already it's already very bad. And in order to prevent a cervical cancer, which may or may not happen 40 or 30 years down the road, it's I don't think it's worth it. But at least we can talk about it. And so that's my conclusion. I thank you for your patience.
Dr. Senahagi, I'd like to thank you so much on behalf of all the delegates here today. Again,